Robert, that was an excellent lecture. I can't follow after him. It's impossible to do a better lecture than that. But I would echo the same sentiment when I first met you during this meeting. It was felt like an old friend. And for me, because in Singapore, I was the first interventional pain physician to do endoscopic. So there was a huge amount of resistance. There will be some surgeons among the audience here. I don't know why, but then there's always this animosity between the surgeons and the interventional pain guys. I don't think that I will take away patients from the surgeons, but there's always this fear that they think that I am doing that. So anyhow, I will just walk everyone through my own learning journey, a personal journey of what I have gone through, rather than a didactic lecture of what Robert has done. He has done a wonderful job. I couldn't have done it better. And he has much more experience than me. So I'll just share a few my experience from my perspective. So I published my data in Journal of Spine under the watchful eyes of Anthony Young. He was my mentor when I first started endoscopic in 2014. So under a tutelage, and he has encouraged me to move on. He was also telling me that yes, I was going to dabble into an area whereby many uncharted territories, people will frown upon what I'm doing, and I must have balls of steel to be able to do this. Because, yeah, there will be a lot of persecution if you may. So I have published my data in the Journal of Spine. So I first started off, and in my paper I said that how would an interventional pain person, physician like myself, even start on this journey? I would say that the first thing to do is that before I started, I was actively involved in treating the disc. I was comfortable treating the disc. So any form of disc problem, in some parts of Southeast Asia, the disc is no-no, cannot touch by the pain physician. It must belong to the surgeon. In Singapore, there was also that kind of murmuring, but fortunately, I was able to show that I had a lot of experience treating the disc. So I started off with nucleoplasty, then I went on to annuloplasty, using the tunnel vision, using the Camden's triangle, etc., etc., and then moving on to bigger needles, such as this FX, and there are other so-called bigger instruments to be able to access the disc. So with all those experience that I have gotten through the years from 2001 until 2014, so I have many thousands of patients for nucleoplasty, annuloplasty, disc FX, etc., etc. And I feel that that should be the starting point of anyone who wants to go and start doing endoscopic spine surgery. So at least you are comfortable knowing how to treat the disc. That's what Robert said. It is a different ballgame altogether. It is not for every single pain physician. You must be pretty committed. You must stand in the trenches, just like a spine surgeon. There's no backing off. When you're pushed against the wall, you have to make decisions. You have to decide what to do. So the Camden's triangle, like what Robert has mentioned earlier, being this triangle here, followed by the superior articulating process, or the so-called the transverse nerve, as well as the lateral exiting nerve root and the upper end plate of the lower vertebrae. So that is the very safe triangle that we want to go for a transforaminal approach. And that's how it all started. Understanding how to get into this space using the different ways of whether geometric or calculations method. So in my experience, I've done 80 over cases We have added a few more since that time. And I have done transforaminal decompression, interlaminar disc decompression, as well as interlaminar canal stenosis decompression. So for the transforaminal decompression, my approach inside out when I first started off, then I moved on to half in, half out. What inside out means that my cannula, where my introducer and my cannula working channel is actually in the disc, inside the disc, then move out from within the disc to see the surroundings. So once you are inside, it's a safe place. Then from there you work out slowly. As I get more and more comfortable, as I get more experience with it, I moved on to an outside in approach, which I'll show you. If I come in from the outside, but that means I am in a free space. I got nowhere to dock my cannula or my introducer, and I need to be comfortable with that idea. As well as moving on to stenosis decompression. So some of my statistics, the age group range anything from 20 years old all the way to 80 years old. The large bulk of it is about 60 to 80 years old here. So in terms of the disc itself, most of the patients will be all within this age group of 30 to 60. In terms of stenosis, whereby posterior animal stenosis, most of my patients will be always around the older age group of 60 to 80 years old. Generally, I do not offer this to every single patient. So after the patients have failed conservative, have failed any kind of pain procedure, and the pain continues to persist at a high level, distressing level, 7 out of 10 with great disability, claudication distance, functionally they are affected and they cannot function every day. And more importantly, the MRI itself also shows that there is significant compression of a grade 1 or more, then I will consider doing that. And I need to exclude spinal instability. I don't have ASA 3 to 4 type of patients. If there is a spondylolisthesis, I will also maybe not want to do that for the patient. And I will only choose, when I first started off, single level disease. Many patients have got 2 discs, maybe have multiple canal stenosis, but I will only choose those that are at single level, something that I can manage, so that I don't get myself into trouble. So in preparation of the patient, in Singapore, I will always offer the patient the options of open surgery, because the surgeon is all looking at me and saying that you are doing something illegal. You will go to hell for this. So I have to offer to the patients, yes, there is a surgical option, and that is the gold standard. They have been doing that, the decompression, using surgical laminectomy, etc., etc. I'm here, I provide an alternative. Yes, I have a less invasive approach through a transforaminal or even through an interlaminar approach. I give them the second option. I give them this, there will be less invasiveness. Yeah, in terms of outcome, it may be the same. So the patient is aware, they are informed, and they give them consent for that. I will talk to them about dural tear, dural injury. I'll talk to them about nerve injury. I'll talk to them about infection and bleeding. So all these things are all spoken. I even talk to them saying that a possibility that I may actually have to open, that means I move on from a endoscopic, minimally invasive procedure to an open technique, and that's a possibility. There's also a possibility of recurrence, of pain, or pathology. And I will always have to find a doctor, a neurosurgeon, a backup, especially in my initial years. When I first started my initial cases, I will always have a standby in the event of some complications that will pop up. So my patient selection, all those within by the grade 2 kind of disc herniation, resulting in canal narrowing, where the straightening race is less than 60 degrees. I do not handle the high migration as Robert. Robert is an expert in this. I would also caution anyone starting off endoscopic to not consider migration, high-level migration, whether it's superior or inferior. Inferior is more forgiving, superior is what we call hairy, scary land. So there's always issues with nerve injury in that area. So start off with no migration or very minimal migration for your patients. So this is one example, the typical kind of example, a grade 2 to a grade 3 type of disc herniation resulting in canal narrowing, the facets are large. And interestingly, this is actually a re-herniation or recurrence of a post-surgical patient. The patient has really gone for discectomy. The patient has a recurrence within a year, came to me and wanted an alternative. So yes, we actually did for what we call a transformational endoscopic approach. So I keep my levels between L3 and L4, 2 levels. Can I do L2, L1? Sure, of course, but I think the starting journey, you want to keep yourself safe, you want to keep yourself in a space whereby you'll be comfortable. L3, L4 will be safe. I've used Joymax, Eloquence, Richard Wolfson, especially of late, I've been using a lot of Maxmore Hoogland technique, whereby it has its advantages, but it's also not for everyone. There's a bit of a learning curve to that. For the L5 first one, I find that the interlaminar approach for the disc decompression would be more suitable, partly because of the high riding eyelid crest. The eyelid crest is always in the way. Of course, there are many ways to overcome that. You can go in from an angle, you can get that. But I liked, when I first started off, I wanted to keep my journey simple and uncomplicated. So I decided to just keep all my L5S1 to an interlaminar disc decompression. After that, I always supplement with some of the facet de-innovation of the medial branch to give them a complete so-called outcome. So for the standard preparation, I use a Wilson table for that. And then there are various kinds of measurements. As I said, Robert have actually done all the calculations, geometric or whatever, and those are, you will get to know that there are certain measurements that you will have to take, whether it's from an AP, horizontal, vertical, as well as lateral. And then after that, once you have done all those markings, you plant where your needle will go, and then you decide. I usually will encourage people to do an inside out for the start, because once you dock your cannula inside, it's safe. From there, you work within that. Of course, the trouble with it is that once you push your cannula into the annulus, everything looks funny. It doesn't have a normal structure. It doesn't look normal at all. Hence, that's why we talk about the distortion of the ruptured disc, and then you need to get used to looking at all these things. Whereas if you do an outside in, it actually prevents disc injury, and then you can actually see the disc nicely, and you can approach it, and you can take your time to so-called decompress it, but this takes a bit of a learning curve. So, one example of how I usually would do that, first of all, I will usually light up my disc. In some places, maybe Robert doesn't do. For me, as I first started off, I always stain the disc herniation using Mr. Liquid. So I will put a needle in, and I will stain it and see that the herniation comes up, and that's where I want to go. Then after that, I use a Tom Sheedy needle, hit on the SAP, go past that, and then I change it to a blunt Tom Sheedy, and then get into that space. And subsequently, you'll keep drilling sequentially until you reach 8 millimeters or 9 millimeters. So the end point of where my cannula ought to be when I first put in the endoscope, the cannula, the sheath, it should go past your medial particular line. There's always this fear that I will be going in too far medially, I'll hit the neural structure, I'll be in the epidural space. But we need to overcome that. So this is important to go past the medial particular line, and you need to, for the lateral, you need to go past the posterior vertebral line itself. And then once that's done, you will find that you will be able to get into the disc herniation. So this is a outside-in approach whereby I have really cleared open up the space And once I click open, because I've stained the disc blue, so it can actually see that this is the disc herniation looking at me. Just for orientation, the top is where the facet is. Yeah, this is the foramen I'm going in. So the disc has kind of lifted it up, and it has obliterated the whole entire space, whereby the epidural space cannot be seen at all. Then once I have punctured the disc herniation, where I think the maximum where I want to go in, the best place to enter, I will go in with the grasper, and then we will just the rest of it is easy. I think the difficult part is planning where the cannula, planning where your endpoint. When you first open up your endoscope and you see things that you are not familiar with, and that's scary stuff. Then you need to stay calm and get your bearings, and then finally work it out. This is the easy part. So that is a transforaminal approach for this herniation. So I moved on to things that I also will treat patients with canal stenosis, whereby there is predominantly posterior element, facet hypertrophy, thickened ligamental flavor, whereby they have failed all kinds of epidural or any kind of dorsal ganglion or neuroplasty, etc., etc. And generally, minimum the MRI grade 2 and above, 2D and above, with effacement of CSF. I try not to do more than a grade 3 because I will find that it's great difficulty, or I may get into problems of duodenal airways. I will share with you that's just what happened. So this is the kind of canal stenosis that I will attempt. I think that this is the kind that I will not attempt. It has already gone to a grade 3, whereby the whole entire canal space is not. So for interlaminar canal decompression, I do L4, I've done L5, I keep it to these 2 levels. I've gone from ipsilateral to a contralateral space as well to decompress the whole area with exposure of the impinged nerve root. So after once we have visualized the exiting root is free, then again I will always end off with a frequency of the facet. Of course, now with the new technique of what Robert has shared yesterday with using the endoscope, we can actually look at the facet and do a capsulectomy, and then that will give you a fantastic result. So this is the interlaminar. Once you've gone in, you've done the bone works and all that, you have now go into the ligamented flavor, and you're able to pull out the thickened flavor by itself. Yeah. I think the advantage of an endoscope is the irrigation technique, whereby things are under water and it's irrigation and everything looks very nice. This opposed to the traditional discectomy or the interlaminar laminectomy. That is a dry, whereby everything is very much different. So I think the advantage of us having all this so-called irrigation with water, with all that, it actually helps us a lot, because irrigation pushes things away and it helps us to give us a margin of safety as well. This is using a diamond burr to burr the residual facet hypertrophy that I couldn't clear enough. And then subsequently, there are more ligamental flavor that's stuck holding down the nerve root itself. And yeah, this is another. So Robert was mentioning about bleeding and all that. So bleeding is something that can be very hairy for interventional pain physicians. We don't like to see blood. The moment we see blood, we panic. So this is something to get used to. You will see, you need to be able to get used to seeing blood, what to do, and be mindful that as long as you're not hitting an artery, venous bleeding can be very dramatic, especially under the scope. Everything is all red, and you have to keep calm and be able to kind of find a way and use your ablator to be able to either ablate it or use pressure effect or various ways of attending the problem. And then after once you've decompressed adequately, you will see the exiting, and then you see the transversal of the cell. So just a summary of some of my patients that I've done. Starting pain score, 1 day, 1 month, is very encouraging that they have very good functional improvement, and they have very high pain satisfaction score. So some complications that I've encountered itself. Recurrence of pain. I have 10% of patients that after doing that, the pain came back. Yes, frustrating, but it can happen. Another patients whereby, how did that happen? Is because the patient had what we call the DM, the spacer, and after I decompress, the thing still continued to have pain. Second patient was my early days whereby I have inadequate decompression. A repeat MRI showed that I'm still having up to 70% compression, so the patient needed to follow on with a laminectomy decompression. Other types of patients that I have had is that whereby I was unable to visualize the nerve root. Robert was saying earlier, whereby the end result is that you need to see a free dura, free transverse nerve, and or if there's an interlaminar, you must be able to see the exiting root itself, and they're all free. So once they're free, then you can say that that's the end of the procedure. I had one dura tear, unfortunate, yes, but this was a very minor dura tear. Actual fact was that I actually left it alone, but because I was being watched by my surgical colleague, so they flagged it up and they brought this big thing into the medical council and wanted to hang me for that. So yes, fortunately nothing happened to the patient. The dura tear is just asymptomatic. The patient didn't have any sequelae. The patient was fine. I closed it off and everything. But because of once the dura tear happened, I was unable. I didn't continue to proceed to decompress the canal stenosis adequately. So I left the procedure halfway. And once I got the dura tear, I decided to close it. So the patient actually needed a primary decompression further on, not because of the dura tear, but because of inadequate decompression of the canal stenosis. So some parting thoughts is that number one, as you start off, pick your patients well, try not to have too high migration, single level disease, those are very good. Importance of positioning of the patients is very important. You need to know about radiological landmarks. Your mind must be able to visualize what it means by medial particular line, what it means by posterior vertebral line, etc., etc. So all these things are important. Two, always start with an easier technique such as a transforaminal inside-out technique rather than outside-in. It helps you a lot if you have intradiscal staining of the dye that will be able to light it up blue. Then when you go in, even if you don't know where you are, you see blue, you can go towards that direction. Interlaminar disc decompression, it is something that I would say only do it after you've done maybe 50 of such cases of a transforaminal before you do an interlaminar. And when you do that, be mindful that yes, bony works first before you go into the flavum. And there are various ways of the flavum treatment. You can do a splitting, you can do a cutting, etc., etc. At the end point, always try to see the free movement of the dura exposing the transverse nerve root, so that you can say that yes, the chance of the patients, if the pain recurs, is not because of inadequate decompression, not because of an inadequate surgery. Recurrence of the disc herniation itself is definitely possible. So after we have decompressed, we have made a annuloplasty, we have made a nick in the capsule of the disc, so we can actually go and seal it up using the radiofrequency to be able to seal up the nicks. Canal stenosis itself is not for everyone. I think it's something that we need to be careful, but once we actually can mobilize it, free the nerve, do a side-to-side traction, that will help us to so-called ace the outcome. Primary pain reduction and functional improvement. Sometimes, especially for cases like discogenic pain, this becomes a bit of a difficult area, whereby the endpoint is not trying to so-called decompress a disc herniation. The endpoint is saying that yes, we'll do an annuloplasty under the scope, and we hope to be able to achieve the pain relief and functional improvement. So that becomes something that we have to discuss with the patient. try to do the technique whereby there's least amount of bone resection to allow for bone conservation. And most important, before you start off, do go and get attachment. Attached to Robert. He has had thousands of patients, he has had that kind of experience. Be attached to him, learn from him. I have the fortune of being able to be mentored under these various people, Anthony Young, Kompabit, Girish Gata, and Troy, as well as so I actually went there, I get so-called attached by them, follow them, watch, observe, ask them questions, and be fully immersed in it before you even start your first case. Thank you for your attention.